You know, we don't really think about the plumbing inside our own bodies. That is, until something goes wrong. Today, we're going to dive into a really common but super tricky problem called a ureteral stricture. Think of it like a kink in a critical pipe. And we're going to explore the amazing, high-tech, and honestly revolutionary ways surgeons are fixing it now. Let's get into it.
Okay, so first things first, a quick anatomy lesson. What you're looking at here is the ureter. It's this small muscular tube, you've got one on each side, and it's basically a one-way street for urine. It carries urine from the kidneys, where it's all made, down to the bladder to be stored. It's a simple job, sure, but it is absolutely essential for keeping the whole system running smoothly.
So, that leads us right to the big question, doesn't it? What actually happens when this tiny but super important tube gets blocked up or kinked? Well, the consequences can be pretty serious, and they can really mess with a person's quality of life.
And that blockage, well, that's what doctors call a ureteral stricture. It's a narrowing that causes all that urine to back up, which can damage the kidney and cause a whole bunch of other problems. It's actually a surprisingly common issue, but finding a real permanent fix for it, that's been a challenge for a long, long time.
So what's causing this? Well, a stricture is basically a narrowing of that inside channel, which is called the lumen. And most of the time, it's caused by scar tissue. Just imagine a clog forming in a pipe after it's been damaged, maybe from a previous surgery in that area, or a big kidney stone that got stuck, or even from radiation therapy.
For decades, the only way to fix this was with a major open operation. But that has all changed. So let's talk about the solution that has completely shifted the paradigm: robotic surgery. And no, this isn't science fiction. It's the new gold standard for this kind of complex repair.
And to really appreciate what a huge leap this is, just take a look at this timeline. I mean, we've gone from the very first attempts back in 1912, where they were using parts of the appendix and making these huge incisions, all the way to today's robotic platforms that give surgeons unbelievable precision through just a few tiny openings.
And here's where you really see the difference, side by side. Compared to that old-school open surgery, the robotic way means smaller incisions, way less blood loss, shorter hospital stays, and a much, much faster recovery for the patient. But maybe the biggest game changer of all is the incredible dexterity and precision it puts right into the surgeon's hands.
But here's the thing. It's not just about having a fancy robot. It's all about how surgeons are using it. They've developed a whole new toolkit of principles and technologies to make sure they get the best possible result. So let's look at a few of the most important ones.
First up is this brilliantly simple idea called ureteral rest. Now, this might sound a little weird, but before they do the big repair, surgeons will often take out the temporary internal tube, the stent, for about 1 to 6 weeks. It lets all that inflammation in the area just calm right down, which makes the tissue healthier and way easier to work with when it's time for surgery.
And you might be wondering, does this simple trick really work? Well, take a look at the data. It's pretty incredible. These studies show just how effective this little rest period is. You can see the rate of the stricture coming back just plummeted. That's a huge improvement in patient outcomes, just from letting the tissue take a break first.
Okay, so the tissue is less inflamed, which is great. But now, during the actual operation, the surgeon faces a huge challenge. How do they know exactly where the healthy tissue ends and the scarred, unhealthy tissue begins? I mean, how can they be sure they're connecting two good ends?
And the answer to that is just awesome. It's almost like giving the surgeon superpowers. They use this special fluorescent dye called indocyanin green, or ICG. They inject it, and the robot's special camera makes the areas with good blood flow light up in this vibrant green. So on the left, you see the normal view, but on the right, with the dye, bam! The surgeon can see exactly which parts are healthy and ready for repair.
All right, now we get to what might be the most fascinating part of this whole story. Sometimes, for really long or complex strictures, you can't just cut out the bad part and sew the ends back together. You need a patch. And where they get this patch from is just genius.
Yep, you heard that right. Surgeons found the absolute perfect material for a living biological patch in the most unlikely of places: the soft, squishy lining on the inside of a patient's own cheek. This is what's called a buccal mucosa graft, or BMG. And you can see here, the surgeons take a small piece of this tissue, which, it turns out, is remarkably similar to the lining of the ureter. Then, using the robot, they stitch this graft right over the narrowed section, basically acting as a patch that widens the pipe and lets everything flow freely again. So, the million-dollar question: does it work? Oh yeah. The answer is a resounding yes. Across a bunch of studies, this incredible technique, combining that robotic precision with a piece of the patient's own mouth, has a success rate of over 90%. For patients who are facing things like chronic pain, infections, maybe even losing a kidney, that number is everything. It's a ticket back to a normal life.
So, with all these amazing tools in the toolkit, how does the surgeon pick which one to use? Well, fixing ureteral stricture is definitely not a one-size-fits-all kind of deal. It's more like they have a whole menu of options, and they have to choose just the right one for each individual person. So they run through a kind of pre-flight checklist. Where exactly is the stricture? How long is it? Is the tube completely sealed off? Has this person had radiation there before? All of these questions help them figure out which technique is going to have the best shot at success.
And this is kind of what that decision-making process looks like. This complex algorithm is the roadmap they follow. Now don't worry, you don't need to read every little box here. The main takeaway is just how personalized this all is. For one person with a short blockage, the map points to a simple reconnection. For another with a long, scarred stricture, the map guides the surgeon down a totally different path, one that leads to using that amazing cheek graft. It's a custom-built blueprint for success.
And really, to wrap it all up, this quote from the experts who wrote the research just says it all perfectly. This combination of robotic tech, advanced imaging, and these super innovative grafts has totally changed the game for how doctors treat this condition. It really makes you think, doesn't it? We're literally using the inside of someone's cheek to fix their urinary system. It just leaves you with this one final fascinating thought. What problem are we going to solve next by cleverly borrowing from another part of our own bodies?